الجاهلون قالوا سلاما والذين يبيتون لربهم سجدا وقياما والذين يقولون ربنا اصرف عنا عذاب جهنم إن عذابها كان غراما والذين لا يدعون مع الله إلها آخر ولا يقتلون النفس التي حرم الله إلا بالحق ولا يزنون ومن يفعل ذلك يلقى أثاما يضاعف له العذاب يوم القيامة ويخلد فيه مهانا إلا من تاب وآمن وعمل عملا صالحا فأولئك يبدل الله سيئاتهم حسنات وكان الله غفورا رحيما ومن تاب وعمل صالحا فإنه يتوب إلى الله متابا والذين لا يشهدون الزور وإذا مروا باللغو مروا كراما والذين إذا ذكروا بآيات ربهم لم يخروا عليها صما وعميانا والذين يقولون ربنا هب لنا من أزواجنا وذرياتنا قرة أعين واجعلنا للمتقين إماما أولئك يجزون الغرفة بما صبروا ويلقون فيها تحية وسلاما خالدين فيها حسنت مستقرا ومقاما قل ما يعبأ بكم ربي لولا دعاؤكم فقد كذبتم فسوف يكون لزاما.
MashaAllah. Thank you everyone for joining the first grand round of the academic year. So the history today will be presented by Abdullahi Mohamed, a level 6 MBCHB student, together with Abdishakur Nchoki, an incoming level 5 BFAM student. The discussion will be done by Najma Ali, a level 6 MPCHB student, and they'll be mentored by Dr. Ahmed Dekow. I don't know if the doc still is in. Can anyone confirm for me? Dr. Ahmed, are you in? Abdullahi, could you kindly call the doctor? Confirm if you joined the meeting or not. Let's give the doctor a few minutes, around 5 to 10 minutes, for him to join the meeting.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah. Please carry on. I think I had a problem with logging in with the system.
Okay.
Now I can hear you. Just carry on with the case.
Okay, inshallah. Thank you so much, Daktari. So we'll start, inshallah. So I'm presenting TM, 20-year-old male, resident of Mwangi, Mwingi, Form 4 graduate. A referral from Kitui Level 5 Hospital with elevated urea of 93.56 and creatinine of more than 2,000 for hemodialysis and further management. And the date of admission was on 24th December 2023. Before referral to our facility, the patient was stabilized and transfused 1 pint of blood. The main reason he was referred to our facility was for hemodialysis because he had deranged UECs. He presented with a low HB of 5.9 and he was in a state of confusion. So 1 month prior admission, the patient presented with lower limb swelling for 1 month, cough for 1 month. So history of presenting illness, patient with no comorbid illness and seronegative was well until 1 month prior admission when he developed sudden onset bilateral limb swelling extending up to the knee that started from the foot and progressively increased up to the knee. It was tender, persistent, associated with shortness of breath, New York Heart Association, grade 3. It was associated with the paroxysmal nocturnal dyspnea, general body malaise. It was relieved by resting, elevation of the leg, and exacerbated by sitting for too long and walking. Patient also presented with complaints of confusion, as I had mentioned earlier, because of the low HB, altered mental status. He was dizzy, palpitations, all features of anemia. Patient reports no history of periorbital edema, early morning facial puffiness, but reports so there was no history of periorbital edema, early morning facial puffiness, but the patient reported anuria, which was preceded by episode like 2 days before of oliguria. There was no history of dysuria, urgency, nocturia, increased frequency of urination, no history of hotness of body, chills, urethral discharge. Patient reports no history of abdominal swelling, right upper quadrant pain, pale stool, dark urine, yellowness of the eyes, no increased bleeding tenderness. Patient also experienced sudden onset cough, which was productive, sputum, which was productive with streaks of blood, filling half teaspoon in every episode, non-foul smelling associated with diffuse chest pain, relieved by the over-the-counter drugs. No exacerbating factors, no history of contact with TB, no night sweats, no weight loss, and history of chills or fever. Patient reports 4 episodes of vomiting, which were intermittent. Vomit has contained streaks of blood and food content. It was non-bilious, non-projectile, mostly postprandial, associated with hematochezia, epistaxis. No history of previous similar episodes or familial history. No history of alcohol or smoking. No history of familial renal disease. No history of sore throat, pharyngitis, joint pain, rash. No history of malar rash, photosensitivity rash, muscle pain, muscle weakness, or early morning stuffiness. No history of nephrotic drug use. The aminoglycosides, gentamicin, amphotericin, aspirin, and the rest. Since admission, patient had received 6 sessions of dialysis. Chest tube placement was done. Chest X-ray, urinalysis, echo. Patient developed high blood pressure. Highest reading was, as he was being managed in our facility, he had episodes of hypertension with multiple readings. So the latest one was a systolic BP of 152 over diastolic of 91. And he was immediately started on the antihypertensive. Initially carvedilol, nifedipine, which was later, nifedipine was changed to hydralazine. Patient improved tremendously and was due for discharge when he suddenly developed acute dyspnea, cough, desaturation, and worsening clinically. So initially, this patient, everything was well, and we were waiting for discharge, but he suddenly deteriorated. So unfortunately, we lost the patient, and we lost the patient on Thursday, 8 February 2024. And just a few days, he was well and waiting for discharge. So on further questioning, we came to note that the patient had developed persistent hyperkalemia that was refractory to treatment 3 days before his discharge. So past medical history. So I'll hand it over to my colleague Abdishakur to continue with the past medical history.
Hello, Abdullahi, can you hear me?
Yes, I can hear you.
Okay, so should
Yes,
I share
Shakur,
my
hold on.
screen?
Shakur, hold on a
Okay.
sec.
Okay.
Yeah, so before we continue the past medical history,
Okay.
is there anything that the colleagues who are listening to the initial case presentation, are there any questions in that initial presentation? Especially the HPI, given that how this is a young patient, 20 years old, who's had history of dialysis, and unfortunately there is a demise. So is there anything that you guys want to know before we continue with the past medical history? Are there clarifications? Are there questions? If there are none, we will proceed to the past medical history straight. Okay, Abshakur, carry on.
Hello, Chairman, I have a question.
Yes.
Yes, Secretary.
They say that the patient died because of hyperkalemia, persistent hyperkalemia, and which was not managed by the drugs, huh?
Yeah.
Okay.
Yeah.
Can you tell us, like, how did they manage hyperkalemia? And since the patient was also on dialysis, and remember, one of the indications for dialysis is electrolyte imbalance, particularly hyperkalemia. So if the patient was on dialysis and had hyperkalemia,
Yeah.
which drugs were given to take hyperkalemia, and did they take the patient for dialysis again because of the persistent hyperkalemia? It's also an indication of that.
Yeah, Doc, initially, I think it will come also in our management. This patient presented with elevated urea and creatinine of more than 2,000. He had 6 episodes of dialysis, and the management that was put on, he was given, for example, for hyperkalemia, he was on K-check. He was, but when we were doing our urinalysis, we had like 4 times we did, the creatinines were coming down to 700, 900. The latest one before he passed on was 792. So still, despite the dialysis, there was a persistent elevated creatinine and hyperkalemia also. It started from 7, then came, the latest one was 5.9. So perhaps maybe that could have been, yeah, the K-check and dialysis were the management modalities that were made for the hyperkalemia, but the levels were a bit coming low, not compared as before, but they were still high. With the latest one, it was 5.9. And he came with around 7.1. So maybe perhaps that could have been the persistent hyperkalemia that was not responding to the management. So yeah, and also there were some also, I think towards the last week, the patient also missed, I think, 2 episodes of dialysis within that week. So was it because, we are not sure, because was it because of the low HB that, or because of, but that were among
fair enough, Lectari. I think this is a question that needs to come at the end of the discussion. So Dr. Khalif noted your question. We will address it once the case is over. Probably maybe there are a few things that would make sense at the end that will actually clarify your questions and your concerns.
So, Shakur?
Doc, I have a question.
Okay.
Okay, this patient, before he came to Kenyatta, he had deranged UECs. And in the history, there is nothing that's directing us what may have precipitated the deranged UECs.
Okay.
So in the course of these deranged UECs before they presented for dialysis?
That's an excellent question.
Yeah.
Okay, but you see, we have just had a history of presenting illness alone. So I think all your questions might actually be coming towards the very end. So I have a very clear answer for that one, but I think I don't want to preempt. Let Dr. continue the past medical history. And then once we're discussing what happened and what kind of an impression we've made on the initial definitive care that was done, that is when we will either maybe that question will self-address, or probably we will point out to it in case it's not clear by then. Dr. Abshakur, continue with your presentation. You can see the number of questions people are asking. So yeah, I hope by the time you're finishing, some of these concerns would be addressed. But please, if those questions are not addressed, you can ask them once again, so that once we have a clear-cut history and a few investigations that were done, then we can actually address most of those concerns and questions.
Through the past medical history. First, I'd like confirmation that you can see my screen and it's visible and clear. Sure.
Yes, Dr.
So for the past medical history, as Abdullahi mentioned above, the patient had a history of blood transfusion while he was in Kitui Hospital, and there was no previous surgery done, no known food or drug allergies, and also there were no known chronic illnesses. For the family and social history, the patient was the last born in a family of 9 children. The rest of the siblings are all well and alive. There's no familial chronic illness or cancer that was noted. And the patient also lived with his mom and dad and siblings in Mwingi. He was a Form 4 graduate, and the NHIF was active. So during the review of the system, the results that were obtained after reviewing the systems, that's the ear, nose, and throat, the musculoskeletal system, the skin, the results were unremarkable. So there was really nothing. It was unremarkable. So for the summary, TM was a 20-year-old male. He was referred from Kitui Level 5 Hospital to a facility for hemodialysis and further management. He presented with history of bilateral lower limb swelling for 1 month. Also there was cough for 1 month, and also paroxysmal nocturnal dyspnea, odopnea, and shortness of breath. So while using Kitui, he received 1 pint of blood while using Kitui, and during his stay here, he received 6 episodes of dialysis, and he was also given antihypertensive, but he clinically deteriorated due to persistent hyperkalemia and succumbed last Thursday, that was on 8th of February, 2024. So during the general examination, the appearance of the patient, he was sick looking, in respiratory distress, on oxygen via mask, and also his orientation to time and place wasn't right. His vitals, he had high blood pressure, you see 152/91. The heart rate was 96, the respiratory rate was 20 breaths per minute, and his temperature was at 7 degrees Celsius. For the JACOL examination, the only positive was pallor, specifically conjunctival pallor. Also, on inspection and palpitation and percussion of the CVS, abdomen, CNS, and gastrointestinal system, the results are unremarkable. The only results that were very important here were the respiratory system. And on inspection, he had tachypnea. That word is really hard to pronounce, but you guys can see it on the screen. The use of accessory muscles, lateral thoracostomy, and no chest deformity. That was during inspection. During palpation, there was symmetrical chest expansion, tracheal and central, and slightly deviated to the right. On percussion, resonance throughout the lung field, and on auscultation, those bilateral equal air entry and the vesicular breath sounds. So for the abdomen, we mentioned the CNS and the gastrointestinal system. The results were unremarkable. So the impression that we had was cardiorenal syndrome, where there was also acute kidney injury. So for differential diagnosis, nephrotic syndrome and acute tubular necrosis. I think that's where I'll be presenting up to, and Abdullahi will be taking us through the working diagnosis.
So in our impression, then just to clarify, yeah. So in our impression, originally from the history, it was very evident that there was a feature suggestive of cardiorenal syndrome, because the patient, despite the renal manifestation, he was still on. He still had elevated hypertension, elevated blood pressure, and also there were investigations, the echo that was done, that clearly showed that there was heart failure, reduced ejection fraction of 38%, and it was very clear that the symptoms have extended to the cardiac system, and also acute kidney injury. The reason we had that in mind is because this patient had no previous comorbidity, and we had sudden deterioration of the renal function within just in a span of 1.5 months. So we had maybe features. Could it be because of intrinsic intrarenal? Could it be acute tubular necrosis or glomerulonephritis, something that was, and also there were some lab results that were done that were suggesting proteinuria in urine and like that. Yeah. So, yeah. So the working diagnosis, end-stage renal disease, was very clear because the patient was dialysis dependent with a low GFR of less than 15. So we wanted to rule out what really made this patient to go into end-stage renal disease within a span of very few months, just 1 month. And we were querying for glomerulonephritis. So we had RPGN, good pasture syndrome. So there was a test that was done, and we ordered for ANCA. So ANA was negative. We were still requested for ANCA and biopsy, so that to know exactly what has caused the end-stage renal disease. Then the cardiorenal syndrome I've already mentioned, and then the bilateral pleural effusion was also a problem. We were querying because initially this patient, we put a tube, the patient, he became okay, but still he had difficulty. Later on, he worsened with cough, dyspnea, desaturation. So we were a bit querying more on why is this pleural effusion recurring every now and then. Then anemia, the patient, initially 8.8 was not bad, but initially had 5.9, and his HB was deteriorating. There was a time it was 7. Then investigations on admission. Now we did several UBCs on admission. As I mentioned already, of significance was the elevated urea and creatinine, and also low albumin was there. HB was low. That was on admission. On 8th also, we repeated, because he was on dialysis, we repeated another UBC, and the creatinine came a bit low, which was 894, urea 41, but they were still high. On 11th, another one was done. Still urea 34, a bit high, creatinine was high. So that was the last one. Now was done on 23rd, still showed that the creatinine were high. Yeah, So echo was done, next. So the echo that was taken, I've already explained that it had a moderate biventricular systolic and diastolic, left ventricular ejection fraction of 38%. Also, there was a moderate mitral regurgitation, tri-speed regurgitation, and pulmonary artery hypertension. And the bilateral pleural effusion was there. So there was a period, just to clarify, there was a period that this patient, initially when we were clocking, was very stable. Personally advised the family for discharge. Then there was a time now this patient worsened, the pleural effusion recurred, he went into cough, desaturation. That's why maybe in our examination, there's a time, it was non-remarkable, and there's a time the patient worsened. Then ANAS negative renal biopsy, we were waiting for it. ANCA, we requested also. Next. So management, so on admission, up to when the patient now stabilized, he was due for discharge, the management plan was obviously dialysis because he had deranged UECs, he came in a state of confusion, so dialysis, we gave erythropoietin, and the hypertensive initially we started on nifedipine and carvedilol. Then later on, we were advised again because the PP, the blood pressure kept on increasing. So we switched nifedipine to carvedilol to hydralazine, 12.5 mg/d together with carvedilol. So those were for antihypertension. Then for the hyperkalemia, K-check, and Lasix initially was for the lower limb swelling. Allopurinol, the reason I inquired it was given is because to stop the rapid deterioration of the renal function. So allopurinol in the renal is used to slow the deterioration. Then esomeprazole for antacid, and sevelamer, mostly as a phosphate binder. So next. So upon deterioration of that review that we done with the team, so the patient now suddenly had cough, dyspnea, desaturation. So the next plan now was to optimize on bone mineral disease, anemia, and the hypertensive. And we ordered for now PTH, repeat of the UECs because they were still elevated, full hemogram, CRP, high resolution CT of the chest, so that to see if the effusion has recurred and what could be wrong with the chest, urine lump, and sputum for gene expert. Yeah. So, yeah, so that was planned, but unfortunately on Thursday now we lost the patient, and now we had to help the family with the next of the procedures. Yeah, so that was our presentation. Maybe any question, any clarification?
Okay, Daktari, thank you very much. I think this is a topic that has so many things to be asked, and I have a feeling by the time you're done, so many people need to clarify so many things. Before I make a remark and an input regarding what I think is happening in this young man and what seems to be the diagnosis and what needs to have been done and a few things that we missed. I already have two questions, one from Dr. Khalif. Why is, I think the question was about the need for potassium. I mean, for why the patient, before we lost the patient because of hyperkalemia, what were we doing? I think how we were managing the hyperkalemia. And then the other question was, there's no history that is a bit obvious in this young man that can easily, whose kidney disease can be attributed to. Probably maybe you expected the traditional risk factors like hypertension and diabetes to be obvious. So those are the two questions. So what obvious history, thing that should have been commented that would have give us an idea of what is happening here? Are there any other questions? Okay. Now, I think Number one, there's so many things that needs to be clarified. A young man like this who has end-stage renal disease requiring dialysis is quite common in our setup. And I think just to give you an idea, the whole reason why we do a biopsy for anyone with a kidney disease is because in most times, number one, our initial evaluation was not conclusive. We have done quite a number of investigations and we didn't have a diagnosis, or maybe it was meant for purpose of prognostication or for purpose of changing or trying to follow up treatment. So when you have a 20-year-old who has had more than 6 episodes of dialysis, who has a renal biopsy that is pending, number one, it means in our initial approach, we do not have a clear diagnosis. We don't have a reason why this young man has got a kidney disease that is already end stage warranting hemodialysis. That has to be very clear, because if the initial indication is clear, and the reason why this 20-year-old is having an end stage renal disease is clear, you don't biopsy the kidney. So if he had a type 1 diabetes, you don't biopsy it. If, for example, there was hypertension that was clearly documented that preceded way before you had a CKD, you also don't biopsy. If it was a young lady, probably with a clear history of, presentation that is in keeping with lupus, and you had a presumptive diagnosis of lupus that is already confirmed, we have anti-double-stranded DNA, Anna was positive, we had a clear presentation, we had a malar rash, the rest of the spectrum of lupus, you don't biopsy. So by the time you're rushing to a diagnosis, you're making a biopsy, is probably the clear diagnosis has not yet been established. And that is actually what you will realize in today's presentation, that most patients who have got a glomerular disease, either the nephritic picture or nephrotic picture, the diagnosis is usually established by a biopsy. We have a few instances where a patient with a minimal change disease tend to have you make a conclusion just because they are responding to steroids. You can easily deduct and say, okay, this is likely, given the age group and demographic, you can actually conclude and say this is likely to be minimal change disease. But most of the glomerular diseases, the definitive diagnosis is a biopsy. We have a few instances, I think we will learn from today's discussion, whereby just after the initial evaluation, if you have a few the lab results and tied with the history, you can deduct and say, okay, this is likely to be type 1 disease of this particular one, or this is anti-GBM disease, or this is nephritic disease secondary to SLE or something else. But in most cases, the definitive diagnosis, the gold standard diagnosis, is actually a biopsy. So to answer Dr. Khalif's question, you will realize by the time you practice in most of our public places, unfortunately, 1 or 2 sessions of missed dialysis is actually very detrimental to the patient. So it's possible that for some reason, once dialysis is missed, of course, you get a repeat UEC. Probably by the time the UEC is coming, the UEC that was requested yesterday comes late in the evening. And then when someone notices the patient has been having hyperkalemia for some time, so what do we do in our setup? We usually just shift. We just give them a dose of dextrose together with insulin. Even Resonium is not even available most times. So, and then a second dose of shifting may not necessarily happen. So if you have hyperkalemia here, unless somebody is willing to do that work for the whole time and the whole night until gets a UEC, then the way the K is actually is acceptable range. Most times, if you don't dialyze, you tend to lose those patients. So hyperkalemia is not optimally managed. In a patient who is on dialysis, trying to shift it is usually not a good way of managing them. If you have a patient who is dependent on dialysis with hyperkalemia, you can easily buy time by just shifting it. But the ultimate goal should be a dialysis, especially if there was a missed dialysis or it was a prolonged for some reason. Maybe there's a catheter that was blocked, or the patient is septic, or the patient is unstable, or in such a patient where you had a history of, paroxysmal nocturnal dyspnea and orthopnea, that we thought probably this is somebody who has something else on top of the nephritic picture or nephrotic picture, whatever that is going on here. The other question regarding why we have the obvious cause is not clear, I think that is what we will learn tonight. That patient with glomerulonephritis, especially those that tend to give you a rapid deterioration, what we normally call the rapidly progressive glomerulonephritis, we actually become end-stage renal disease in weeks or even months. So you don't have a clear history. Just somebody has been comfortably okay in that demographic in a young person, all of a sudden anuric, you do your UECs, you have creatinine that are high, so potassium is probably high, and then you get an obvious indication for dialysis. And most times, until you have a biopsy, you do not know the reason for the end-stage renal disease. So that is what I would have answered in those two questions. So, but generally, my overview, my initial input to this question: a young man, 20 years old, who has got end-stage renal disease warranting dialysis, presenting with cough and lower extremity edema. The cough could be partially, explained by the fact that this is someone who is edematous. So if you have pulmonary edema from heart failure, because we already have an EF of 38%, or this person was requiring dialysis, currently is fluid overloaded, he starts spacing, so probably he has, just like he has the lower extremity edema, he has edema elsewhere. So he could be having pleural effusion, he could be having pulmonary edema. So the cough could be explained by the fact that he has a low ejection fraction, so he has HFrEF. Cough is a presentation. When you have overloaded, fluid overload from CKD for some reason that probably you have skipped your sessions of dialysis, or you have a worsening of your kidney function, you can easily have third spacing and pulmonary edema. Remember, pulmonary edema is one of those acute indications for dialysis, because when you are fluid overloaded, that is refractory to diuretic, that is now warranting, deterioration, and warranting a change of plan. If you can't dialyze, you tend to have a problem, because if you can't diurese, there's no urine output. So this young man, 20 years old, with cough and lower extremity edema, who has had dialysis for some reason for a few days, whose history is not conclusively giving us a picture of what is happening. Most times you do not make sense. If you don't have an obvious, history of, somebody who has had injury to the kidney, for example, for traumatic incident, or somebody who's had sickle cell disease, or a type 1 diabetes who's had recurrent admissions before, and probably you think there was a follow-up of deterioration that you can actually attribute to. Most of the times, unless you biopsy, unless you have a clear histological diagnosis, you do not get a picture. And then the other painful thing is the initial evaluation that were done. For example, the anchor that was done is negative. So I have a feeling probably by the time Dr. makes the other presentation regarding how you approach, and what we initially, your colleagues actually who made the case thought, if we can tie up what we are going to learn from a discussion and what we are going to make a conclusion of this case, if that makes sense, and then the rest of the questions now which are not making clear sense, we will address it towards the very end. So, Dr. is there a case presentation happening?
Yes.
Okay, please, Dr. Najma, carry on. Okay, somebody's asking a clear question here. I think that needs to be addressed before we continue. Did the patient come with cardiac dysfunction that preceded to decline in kidney function? I think that preceded the decline in kidney function. So which one came first? I think that is an important question. Dr. Did this patient have symptoms of heart failure at the beginning, or the symptoms of heart failure followed the dialysis and the kidney disease? Dr. Abdullahi.
Dr. Initially, we were having a conversation even with my senior colleagues, because upon admission, he had symptoms of deranged disease, confusion, which were more of renal. But upon management, he started becoming hypertensive and manifesting cardiac issues, and the echo that was done. So we were having a conversation. Has the renal preceded the cardio, or the cardio has preceded the renal? We weren't sure. Everybody had their opinion. But at the end of the day, it was clear that this patient, perhaps the renal it can be either way, but he had issues at the both system. But we didn't know exactly which one preceded the other one.
Okay, so it's not clear which one came first. Okay.
Yeah, it's not clear.
All right, Dr. Najma.
Chairman, just before the presentation.
Yes, Dr.
I was just thinking, because part of the differentials was RPGN and also glomerulonephritis.
Yeah.
could there have been a role of high dose steroids even before the results of the biopsy came out? Because I don't know, like for me, I think with that history, it's quite keeping with glomerular disease. Huh?
Okay.
But then again, would there have been a role of high dose steroids, or the fact that we have creatinine of 2,000, it wouldn't have helped much?
Excellent question. I will answer it at the end of this discussion. I think it makes sense. Hopefully, Dr. Najma will capture who we're going to pulse and who we're going to give some steroids and what other differential should we entertain. Dr. carry on. Dr. Khalif, just hold on. That question has to come at the very end.
Good evening. My name is Najma, and I'll take you through glomerular disease. What's wrong with this slide? Is everyone able to see my screen?
Yes, Dr.
Okay. So our discussion tonight will be on glomerular disease. We're going to do a little bit of introduction, then we're going to define some terms, and then we're going to go through nephrotic, and then how do we diagnose and how do we manage. So a little bit of anatomy is that most of these glomerular diseases, the primary etiologies are in the glomeruli. Yeah? So we have to know a little bit about the glomerulus. So it's a tuft of capillaries within the Bowman capsule that's formed by three things: the afferent, efferent, and a branch into the anastomosing glomerular capillaries. So afferent arterioles are the blood vessels that bring in blood to the kidneys for filtration. The efferents are the ones that carry away blood that has been filtered by the kidney, and they branch into the anastomosing glomerular capillaries. So there's something called glomerular filtration barrier. Onto the right side of your screen, you can see a picture demonstrating the glomerulus, the Bowman capsule, how structured it looks like. And you can clearly see the efferent and the afferent arteriole on each side. So there's something called glomerular filtration barrier, which is composed of 3 layers. And it's the fenestrated glomerular capillary endothelium, glomerular basement membrane, and the podocyte layer. So if anything happens, structural changes of this glomerular basement membrane is the hallmark of what we call the nephrotic syndrome. Even a picture of nephrotic syndrome can give you that. So if you get to know this, you will be able to relate pathologically and pathophysiology the problem in glomerular diseases. So we're going to define some terms. So we have primary glomerular disease, a kidney disease that's specifically affecting the glomeruli, because from the word primary, it's the problem is at the glomeruli. For example, it's a minimal change disease. Secondary is there is a glomerular problem, but the secondary to a systemic disease like lupus or a disease that's affecting an organ, for example, diabetic nephropathy. Then there's diffuse glomerulosclerosis, where there is more than 50% of the glomeruli is affected, for example, in diffuse proliferative glomerulonephritis. Then we have focal, where there's less than 50% of the glomeruli is affected, for example, the FSGS. And then we have the global, which is the entire glomerulus is affected. Segmental, only part of the glomerulus is affected. Proliferative, an increased number of cells in the glomerulus. Membranous, thickening of the glomerular basement membrane, for example, membranous nephropathy. Sclerosing, for example, FSGS. The scarring of the glomerulus, the sclerosis of the glomerulus. Necrotizing cell death within the glomerulus. And crescentic, accumulation of cells such as macrophages, fibroblasts, and epithelial cells in the Bowman space. So once we go through the nephritic and the nephrotic pictures, diseases, you will see a mixture of all these. Like, for example, you will see a membranous proliferative. You will see a focal segmental sclerosis. You're going to see the crescentic membranoproliferative, something like that. So you can actually, you guys understand where these terms are coming from. Okay? Yeah. Then the other thing is we're going to overview the glomerular diseases. We usually have nephrotic syndrome, and a mixed picture, which is nephrotic syndrome. So some of the symptoms, the hallmark of nephrotic syndrome, let's start with nephrotic syndrome. We usually have 4 core symptoms or 4 manifestations of nephrotic syndrome. Number 1 is the nephrotic range proteinuria, which is greater than 3.5 grams in 24-hour urine. We have hypoalbuminemia, we have hyperlipidemia, and we have edema. Okay. For nephrotic syndrome, on the other hand, we'll have oliguria, which is very classic. We'll have hematuria. You will have a hypertension, okay, and you will have azotemia. So you will have increased derangement of the kidney function test. whereby there's increased creatinine and there's increased blood urea nitrogen. So you can clearly see how the presentation is. For now, for the nephrotic picture, you'll see a bit of nephritic manifestation and a bit of nephrotic syndrome, nephrotic manifestation. For example, you see a patient having nephrotic range proteinuria. At the same time, if you check their urinalysis, they have hematuria. Okay, so that gives you a picture of nephritic. The next, the diagram that you can see clearly outlines how nephrotic syndrome looks like structurally and nephritic syndrome looks like. On the upper part of this diagram, you can see how a healthy GBM looks like, a glomerular filtration barrier looks like, okay? Or a glomerular basement membrane looks like. On your right side, you can see how the nephrotic syndrome looks like, whereby there is podocyte loss and there is fusion of the podocyte processes, okay? Which is the hallmark for usually minimal change disease as well as focal segmental glomerulosclerosis. Then you can see the loss of the negative charge in the glomerular basement membrane is the hallmark of hypoalbuminemia. Usually because albumin is negatively charged and during normal filtration, it's usually repelled. It usually does not go through the ultrafiltrate. But because of this loss of negative charge in the GBM, that's why we have loss of albumin through the urine, thus hypoalbuminemia. On the left side, you can see the nephritic syndrome, whereby we have, it's usually inflammatory, okay? There's an inflammation and then there's cytokine release, and that's why we have the glomerular basement membrane disruption. That's why you can see red blood cells being, oozing from the GBM, okay? Yeah, basically it's that. This is a nice picture I saw on the internet and it's very fancy. It's a nice way of jogging your mind and trying to remember how the nephritic syndrome presents and how the nephrotic syndrome presents. And it's the same thing I mentioned, but it's a pictorial presentation. So let's talk about the main nephritic nephritic causes, nephritic syndrome causes and nephrotic syndrome causes. So let's start with the nephrotic syndrome. We usually have primary or secondary. So the primary is usually minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. The minimal change disease is the main cause of nephrotic syndrome in children. Okay, it's very unusual we see it in adults, but it's the main cause of nephrotic syndrome in children. For focal segmental glomerulosclerosis is the main cause of, no, not the main cause. Diabetic nephropathy is the main cause of nephrotic syndrome in adults, but it's also very, very resistant, a very hard to treat nephrotic syndrome, okay? But it's also present in mostly in the developed countries, focal segmental glomerulosclerosis. The other one is membranous nephropathy, which is also present as a nephrotic syndrome. Secondary causes is usually due to the podocyte damage again. So diabetic nephropathy, as I've mentioned, main cause of secondary nephrotic syndrome. Amyloidosis, whereby the deposition of the amyloid light chain, and there's the lupus nephritis, okay? So lupus nephritis usually comes with a nephritic picture. For the nephritic syndrome, okay, usually have post-streptococcal glomerulonephritis. That's why in our HPI, you guys will see, we were asking about any history of recent pharyngitis, any history of sore throat, any history of joint pains, because streptococcal infection, okay, usually secondarily causes nephritic syndrome. The other one is IgA nephropathy, which is the Badger disease, granulomatosis with polyangiitis. That's why in our management, we ask for ANCA, okay, the ANCA antibodies, okay, because they are usually associated with this. And then microscopic polyangiitis, eosinophilic granulomatosis with polyangiitis, good pasture syndrome. We were querying that, the anti-GBM disease against the type 4 collagen, Alport syndrome, and many others you can see. Even lupus, you can see it's appearing on both sides, nephritic on your right side and nephrotic on your left side, okay? Pathophysiology of nephritic syndrome, we have discussed this at the beginning. So we said the hallmark is inflammation. Inflammation, there's release of cytokine, and then there's glomerular capillary damage, and then there's leaking of the proteins and the RBCs. So that's why if you do urinalysis, you're going to find hematuria, and you're going to find even proteinuria, but it's not as marked as in nephrotic syndrome. You'll find a bit of protein plus or plus, but it's not within the nephrotic range, okay? The other one is oliguria, whereby there's inflammatory infiltrates, they reduce the fluid movement and cause the membrane, leading to decreased GFR. For our case, our patient presented with oliguria, okay? And then anuria, okay? So azotemia, inflammation prevents sufficient filtering and excretion of urea. our patient presented with increased blood urine nitrogen, okay? He presented with increased BUN, and also the lab results from the urinalysis showed hematuria and also proteinuria at the same time. There's also hypertension and edema, which is due to the salt retention, okay? That was for nephritic syndrome pathophysiology. For the nephrotic syndrome, okay, let's start with this one. For the nephrotic syndrome, the hallmark we said is edema, hyperlipidemia, hypoalbuminemia, and nephrotic proteinuria. So the reason why we have edema is because of, number one, loss of albumin. You know that albumin, it contributes to oncotic pressure. And once we lose the oncotic pressure, there is leaking of fluid into the interstitium and then decreased circulating volume, then increased RAS. And once RAS is activated, aldosterone, what does it do? Retention of sodium and water, thus leading to edema. For the other one, we said was hyperlipidemia. Because you're losing a lot of protein through the urine, there's liver compensation. So they start secreting a lot of apolipoprotein, producing a lot of apolipoproteins, leading to the hyperlipidemia. The other common manifestation is loss of immunoglobulins, because we said we are losing any protein that's in the body. So there'll be increased, there's loss of immunoglobulins, IgG, IgMs, leading to increased susceptibility to infection. The other one is hypercoagulability state. We are losing antithrombin 3, we are losing protein C, we are losing protein S. And what does that make? Our blood hypercoagulable. So we are prone to thromboembolic events. The other one is we are losing transport proteins. If you lose our thyroid binding globulin, what happens to the thyroxine? It's going to decrease. Then there is hypothyroidism. What happens to the ferritin? It's going to be lost. Anemia occurring. Vitamin D binding globulin is also lost through the urine. What happens? Decreased vitamin D. Decreased vitamin D, we have decreased absorption of calcium, because we need vitamin D for intestinal calcium absorption. So all this you can see, you can tie it together. You just pick one manifestation and then you go back and tie it. Why is it happening? These are some of we mentioned minimal change disease at the beginning. It's because of the podocyte effacement and flattening. So there'll be damage to the glomerular basement membrane, podocyte, and glomerular epithelium. Okay, and then there'll be leaking of the capillaries. Then membranous glomerulonephritis has a picture of both nephrotic antibodies attack, okay, against the podocytes. Then there's thickening of the GBM, ultimately leading to damage to the GBM. Focal segmental glomerulosclerosis, there's damage to the glomerulus via cytokine T and B cell abnormalities. Then there's injury to the glomerular epithelium, and then there is that. Okay. Yeah, basically you can just pick one and tie it to the rest. Okay. I'm sorry, I'm just near the mosque. That's why the other is going off. We have explained this slide. So how do you evaluate a nephrotic syndrome? We usually do urine dipstick. You can do actually urine dipstick fasting, but we usually use it for screening most of the time. And if you find a 3+ protein in the urine dipstick, very classic of nephrotic syndrome. Hematuria can also be found. For our case, we found that, and it can suggest a concomitant glomerulonephritis. The main one we usually rely on is the urine protein excitation rate. Okay, Doc was telling us the other time that we don't do the 24-hour urine nowadays because it's very inconvenient to the patient. So what we do is two things. We can either do a urea, albumin creatinine ratio, or we can do a urine protein creatinine ratio, either of those, and it will give you the same diagnostic as a 24-hour urine protein. Okay. If you do your urinalysis, apart from the proteinuria, you'll find lipiduria, you'll find fatty cast, okay, and you will find a renal tubular epithelial cell cast, okay. Additional labs you can do is CBC. You'll find increased hemoglobin and increased hematocrit, which can indicate hemoconcentration, because we said the patient is. Yes. So for the basal metabolic rate, for the basal metabolic panel, you'll do your urea UEC, so increased creatinine and increased BUN. Okay. We can have hyponatremia. Okay, dilutional hyponatremia can also occur because of the edema that's present. If you do your serum protein, you'll find decreased total protein and then decreased albumin. We said hypoalbuminemia is a core feature of nephrotic syndrome, and it's usually less than 3 grams per deciliter. If you do your coagulation factors, you'll find decreased antithrombin 3, you'll find decreased protein S, protein C, you'll find increased fibrinogen because of the
as a compensation, and even the hypocoagulable state itself, okay? And then increased D dimers. If you do your lipid profile, you'll find hyperlipidemia. If you do your vitamin D levels, because we said we are using the vitamin D binding globulin, you'll find decreased 25-OH, vitamin D. Inflammatory markers will also be increased ESR, increased CRP, okay? Imaging, the imaging of choice usually renal ultrasound, KUB ultrasound, so we can assess the kidney size and even the shape and even rule out any obstructive uropathies. For nephritic syndrome, again, is the same thing. We can do urinalysis. So if you do urinalysis, you'll find hematuria, which can either be microhematuria or macrohematuria. You'll find acanthocytes, which are RBC fragments. You'll find RBC cast. You'll find mild to moderate proteinuria. You'll find sterile pyuria and sometimes WBC cast. For the blood test, they'll be deranged, so you'll find increased creatinine, decreased GFR. Azotemia is present with increased BUN. For our case, you remember we asked for ANAs, they were negative, yes. So ANAs, you want to rule out lupus nephritis. ANCA, you want to rule out small vessel vasculitides, like the granulomatosis, polyangiitis, and the rest, and even anti-GBM antibodies to rule out good pasture syndrome. You can do renal biopsy. Sometimes it's usually indicated in patients with non-specific disease pattern to confirm diagnosis. For our case, actually, you guys were very quite. I know you had a lot of questions at the back of your mind. You're like, this is not giving a real clear picture. That's the whole point. And even the patient passed away before he actually received his renal biopsy result. It was very unfortunate. For the treatment of nephrotic syndrome, we can have supportive management and definitive management. For supportive management, you can just do a little bit of maintenance fluid. You don't have to necessarily restrict any fluid, but you can decrease the fluid, what do you call the fluid resuscitation, or the fluid you give, the maintenance fluid. Albumin, if it's very low, very low albumin, it's not the first thing we should rush to because of hypoalbuminemia. So if the albumin is very low, for example, 3 grams, 2 grams, you can actually go ahead and do, you can give out albumin. Or if it's refractory edema, an edema that is not subsiding with 2 or 3 diuretics, you can actually go ahead and give albumin. The other one is balanced diet. You give high adequate protein because these patients are losing protein through the urine. So you give high adequate protein. You can do salt restriction, but not necessarily, not all the time, because you know they also need a little bit of salt in your body. So you can actually limit salt kidogo, but not as much as it's not that extreme, okay? But you can actually restrict a bit of salt in your diet. The other one is diuretics, severe edema. Okay, you can give patients loop diuretics, Lasix, furosemide is the first choice. Then you can go ahead and give thiazides if it's not responding well with the furosemide, or you can add a potassium sparing diuretic like aldactone. If the patient has common infections, because we said nephrotic syndrome, these patients are losing their immunoglobulins through the urine, so they're prone to infections. So if they come with infections, you can actually give them antibiotics, preferably penicillin. If they most of them, they have high BPs, ACE inhibitors or ARBs are the choice of antihypertensive drugs for 2 reasons. Number one, it's actually shown that they have antiproteinuric benefit. The fact that these patients are losing protein through the urine because of ACE inhibitors, how do they work? They cause efferent vasodilation. So if there's efferent vasodilation, there is decreased intraglomerular pressure and then decreased glomerular filtration. So the patients are not losing as much as protein into the urine. So there's antiproteinuric effect, and also it has been shown that it's able to slow down the progression of renal impairment. There's one catch in ACE inhibitors or ARBs in nephrotic syndrome or even nephritic syndrome. If the patient has deranged urea electrolytes, patient has increased creatinine, patient has increased BUN, do not give ARBs, withhold the ARBs or ACE inhibitors unless you have normalized the UECs. Why? Because they actually worsen. Because how do they act? If you decrease your intraglomerular filtration pressure, you are decreasing your GFR. And if you are decreasing GFR in a patient who is already having deranged urea and electrolytes, okay, you're going to retain more creatinine, and more creatinine will worsen the kidney function. For patients, because of the susceptible to infection, they are immunosuppressed. You can withhold all live vaccines until 3 months of steroids, or defer until the prednisone is below 1 milligram per kg. Avoid live vaccines because of the, as we had said, they have low immunity, and they can actually, reactivate whatever the disease the patient is being vaccinated against. Pneumococcal vaccination for all nephrotics. You can actually give annual influenza vaccines. You avoid prolonged bed rest because we said they're losing antithrombin 3, they're losing protein C, protein S. They are prone to DVTs or venous thromboembolism. So what can you do that? Tell them to ambulate as much as they can, avoid prolonged bed rest, and you can actually give Clexane as the prophylaxis, as the thromboprophylaxis. Close monitoring daily. You can do daily charting of the urine. You can do a urine dipstick. You can do blood pressure, and you can do weight measurement. Okay, and even fluid input and output chart. For definitive treatment for these patients, you usually give them immunosuppressive therapy. Is the definitive way of counteracting nephrotic syndrome. So you can give glucocorticoids, so which is our first initial choice of immunosuppressive therapy. Prednisone is our first choice of drug, but if the patient has steroid-resistant nephrotic syndrome, you can actually adapt with cyclophosphamide, calcineurin inhibitors like cyclosporine, tacrolimus, and the rest. Adults who are now resistant to these steroids, because initially we usually say that nephrotic syndrome is generally steroid responsive, but if they're having resistance to these steroids and these drugs, you can actually go ahead and biopsy them. For nephritic syndrome management is the same as, almost as same as nephrotic syndrome. You give a low sodium diet, you do water restriction a little bit because we said they have circulatory overload. For medical therapy, if there's proteinuria or hypertension, you give ACE inhibitors or ARBs, angiotensin receptor blockers. If there's severe hypertension and edema, you can give diuretics, which we said furosemide. And if it is refractory, we can go ahead and add another one, either thiazide or potassium sparing diuretic. Sometimes immunosuppressive therapy is indicated. For example, in lupus nephritis. We usually give glucocorticoids, so we give prednisone. We can also give hydroxychloroquine. We give azathioprine. We can give MMF. So you're not restricted. So immunosuppressive therapy is also indicated in nephritic syndrome. If the problem is, if you have identified, you have done a biopsy and confirmed it's a rapid progressive glomerulonephritis, okay, or an anti-GBM glomerulosclerosis, you can do plasmapheresis, because the problem is that there is antibodies that are circulating and attacking the glomerulus and the GBM. So you can go ahead and plasmapherize this patient, and you can reduce the load of the immunoglobulins or the antibodies that are mediating against this patient. In the case of severe renal insufficiency or kidney failure, for our case, we can do renal replacement therapy, for example, hemodialysis or possibly transplantation. For membranous, for membranoproliferative glomerulonephritis, like type 1 or type 2, which we're suspecting our patient could have, the rapid one, RAS inhibitors are often added to the treatments, okay, and even prednisone alone or in combination with other immunosuppressants like cyclosporine or tacrolimus, any immunosuppressive drug, okay, can also be added with prednisone to counteract that membranoproliferative glomerulonephritis. And I'll open the floor to discussion, question and answers time, and thank you so much for listening to me.
Okay. Thank you very much, Najma, for that brilliant presentation. Okay, I just need to put a few things into perspective. Nephritic, these are very complex, enormous diseases for someone to make sense out of it in one bulk, because there are quite a number of diseases lumped up together. And I'm sure this is a group that is made up of so many different level colleagues. So much of this information might just go through without necessarily making it sense at the beginning. But hopefully at the very end, it will make sense. So just to add a few things that are very necessary. Anytime you're evaluating such a patient, a young patient who probably in 30s or mid-40s, still young, who you think probably there is some derangement of UECs, because that is what most people pick at the beginning, and whose initial reason is not clear. Patient actually used to be evaluated for glomerular diseases do not actually have overt signs where you can say, okay, there is a clear reason why this person has a glomerular disease. So what we came up with is like, okay, there's a way we can easily bring these things into perspective. If you have a number of constellation of symptoms, we think probably you have a glomerular disease, and specifically you have a picture that is called nephrotic. As he has clearly mentioned that you have glomerulus is usually made up of, the filtration barrier is made up of three things. We have the capillary endothelium that are fenestrated, that's like any other capillary. You have a basement membrane, and then we have a lining at the end whose cells are called podocytes with food processes. So you have a problem at any of those layers. For example, if you have a problem with the lower layer, you don't have any problem with the cells that are already circulating. So you get more of a proteinuria and not hematuria. But if you have a problem with the cellular lining that is closer to where the circulation, the capillary endothelium, you lose your RBCs, so you get hematuria. You lose your WBCs, you get WBC in urine where there's no infection. We call it sterile pyuria. So the whole idea is you make sense at the beginning by saying, okay, do I have a nephritic pattern whereby there's a glomerular injury at the level of the capillary endothelium, or do I have a nephrotic picture whereby most of the disease is probably at the very end? I can say, okay, if I have a nephrotic picture, there's a constellation of symptoms to follow. You have proteinuria that is significant. We call it nephrotic range. If it is more than 3.5 grams in 24 hours, you have hypoalbuminemia, you have hyperlipidemia, as he has mentioned, you have edema. So anybody with this picture, we say this patient has nephrotic syndrome. And evaluating this patient is easy because all you need to know at your level is nephrotic syndrome is either primary or secondary. If it is primary, there are only three things you need to remember. Is it as a result of minimal change disease? Is it as a result of membranous nephropathy? Is it as a result of FSGS? You don't need to remember so many other things. If it is secondary, the commonest cause of secondary nephrotic syndrome is actually in adults is diabetes. So diabetes is by far the commonest one. In women of reproductive age group, it's preeclampsia. And then amyloidosis, which is not a common thing. The other thing you must remember is lupus, SLE. Lupus nephritis can give you nephrotic syndrome. It can also give you nephritic syndrome. So when you are discussing nephrotic, the primary are the three that I've just mentioned. When you're discussing the secondary causes, the ones that you need to remember are diabetes, preeclampsia, and lupus nephritis. And that is after you have gotten your clear picture that this is nephrotic because I have nephrotic range proteinuria, I have low albumin, I have hyperlipidemia, I have edema. And that is very easy to follow. And most of the times, just by one or two tests or supported by the history, nephrotic syndrome is easy to make a diagnosis. But if it is in the pediatric age group and somebody who doesn't have any reason for comorbid, those are the patients who you tend to evaluate with a biopsy. Once you get a biopsy, if it is membranous or if it's FSGS, they don't tend to have an easier course of progression like the minimal change disease, because minimal change disease is very easy. Membranous FSGS tend to be difficult, and they tend to progress to end-stage renal disease. That is the message you need to pick up from nephrotic syndrome. The nephritic syndrome is slightly more complex. So how do you make sense out of it? It's very easy. You don't need to follow all those things. Number one, there's a problem at the capillary endothelium, but we are not losing significant protein because we said most of the protein lost is because of the glomerular basement membrane downstream and the podocyte. So you're losing protein, but not nephrotic range. So it's subnephrotic. So you're losing less than 3.5 grams in a day. And I just need to emphasize the way you're supposed to do it, if you can't do the 24-hour urine, is by doing the spot urine, where you do a urine protein creatinine ratio or an albumin creatinine ratio. It's not a urea albumin, it's a protein to creatinine ratio or an albumin to creatinine ratio. So if you have less than 3.5, you have hematuria. So the evidence of hematuria is very easy because you can either have frank hematuria, so this person can visibly see there's blood, or you can get microscopic hematuria by just doing a microscopy. So you get anything, anytime you have an RBC cast or a dysmorphic RBC, what is now called here acanthocytes, that is an evidence of hematuria. So if you have hematuria, you have proteinuria less than 3.5, a picture of an AKI and hypertension, that is a nephritic pattern of disease. So it is not nephrotic, and the evaluation is easy. We mentioned nephrotic is either primary or secondary, but nephritic, you just divide them into 3 big umbrellas. So number 1, is it because of anti-glomerular basement membrane? We have antibodies that are destroying the glomerular basement membrane, what we used to call the Goodpasture's syndrome or Goodpasture's disease. It's not a common thing, so you're not even supposed, this is a diagnosis that even a nephrologist will make it once in a decade or once in a lifetime. But that is the first bucket. Is it because of glomerular basement membrane antibodies? And this is the Goodpasture's syndrome or Goodpasture's disease. And this is very easy, because if you get a young man who has got hematuria or a glomerulonephritic picture together with a lung involvement, with hemoptysis, you think about Goodpasture's syndrome. Not a common thing, but that is the first bucket. So do we have an anti-GBM antibody? The second thing is it an ANCA-related disease? So what we used to call the way we call the small vessel vasculitis. Vasculitides are actually large vessel, medium vessel, small vessel. So now we are talking about the small vessel vasculitides. And most of them is because they are ANCA-associated. In this bucket is just called the ANCA-associated glomerulonephritis. So we have 3 diseases under this bucket. So we have what we called the Chag-Strauss, the Wegener's granulomatosis, and microscopic polyangiitis. Nowadays, you don't even call all those big names. You call them GPA, EGPA, MPA. GPA is granulomatosis with polyangiitis, what we used to call Chag-Strauss. MPA is microscopic polyangiitis. And EGPA is Chag-Strauss, is eosinophilic granulomatosis with polyangiitis. These are small vessel vasculitis, and they are very rare diseases. So you may not even necessarily see them as a doctor unless you decide to become a nephrologist. So it's very easy and then the good thing about them is they don't have a limited kidney disease, because they're small vessel vasculitis, you get systemic other diseases. So they tend to give you palpable purpura. Eosinophilic granulomatosis is very easy because you have an asthma patient with eosinophilia who has hematuria, who has a picture of glomerulonephritis. It's easy to say, this is likely to be EGPA. All you just need to do is an ANCA, and the ANCA that you do is P-ANCA. So how do you differentiate these 3? Is easy. GPA has got C-ANCA, the rest, MPA, EGPA has P-ANCA. So P-ANCA, C-ANCA at your level may not necessarily be that terribly important, but we have anti-neutrophil cytoplasmic antibodies. We have antibodies against the neutrophil proteins, if it is cytoplasmic or is it perinuclear. So we call them cytoplasmic for C-ANCA, perinuclear for P-ANCA. For GPA, granulomatosis with polyangiitis has C-ANCA antibodies. The other 2 has P-ANCA antibodies. And then the last bucket is anything that has got an immune complex deposition. Immune complex is very easy. It means antibody antigen. So if you have an antibody antigen reaction that are deposited anywhere in the body, you know what actually activates your complement system. The classical pathway of the complement system is activated by an antibody antigen complex. So what they do, they stimulate the complement system. There's a lot of inflammation, and then there's destruction of that organ. So in this case, because we have an antibody antigen complex deposition within the glomerular basement membrane, you get destruction, and then you get hematuria, AKI, the rest of the nephritic pattern. So which diseases are under this? Number 1, SLE. I've just told you that SLE has lupus nephritis can give you both a nephrotic and a nephritic. So lupus nephritis gives you an immune complex deposition picture that is as a result of destruction of the glomerular basement membrane and capillary endothelium. The second one is a common one, is now the post-streptococcal glomerulonephritis. The other one is MPGN, membranoproliferative glomerulonephritis. This one also is very important to remember. It gives you both a nephrotic picture and a nephritic picture. So all this discussion that we have in the first few things that you need to remember, there are 2 diseases that can give you both a nephrotic and a nephritic. Number 1 is lupus nephritis. The other one is membranoproliferative glomerulonephritis. And then the last one in this immune complex group is a cryoglobulonemic vasculitis that tends to be associated with hepatitis C. So all these diseases, you don't need to remember because they're not terribly important at your level. They're not that common. Please remember lupus. Please remember post-streptococcal glomerulonephritis. So all this bucket of nephritic pattern, the ANCA-associated, the anti-GBM, the immune complex. Those are the 3 that you divide. The ANCA-associated, these are now the post-immune because we don't have any immune staining on IF. So the small vessel vasculitis, they're very rare. Anti-GBM, very rare. The one that are common is the immune complex group, the post-streptococcal, the SLE, the MPGN, and then patients who tend to have hepatitis C has cryoglobulinemia. And something that is very common about all this immune complex is because there is overstimulation of the complement, you have low C3, low C4. So you get hypocomplementemia. So you realize in the initial evaluation, there's a complement level being requested, so that if you have a low C3, you don't even bother about ANCA or anti-GBM. Already you're narrowed down to something else. That classification is very important when you're discussing a patient with nephritic picture. I'll just repeat one more time. Nephritic pattern in terms of the causative agent is divided either into an ANCA-associated disease, and that is the small vessel vasculitis. We have 3 diseases there: GPA, EGPA, and MPA. We have the anti-GBM, just one entity. We have antibodies, that's the good pasture disease. And then we have the immune complex mediated. So under the immune complex mediated, we have SLE, PSGN, MPGN, and the hepatitis C associated cryo. And then within that immune complex, we have IgA nephropathy. The reason why IgA nephropathy is not added lumped up at the initial thing, you know that you remember that IgA does not stimulate the complement as aggressively as IgG. So they don't give you a low complement. So IgA nephropathy, the Buerger's disease, which is actually the commonest cause of nephritic disease worldwide, not very common in our setup, is also put under the immune complex, but does not give you low C3, low C4. And then if you have an IgA nephropathy together with an extra renal manifestation, especially in the pediatric age group, it gives you a new disease called the Henoch-Schönlein purpura. That's all that you need to remember. So nephritic syndrome looks very crazy, looks very complex, but most of the time you realize by the time you're making a diagnosis, it doesn't actually have to come to you at your level. It's mostly supposed to be a problem for the nephrologist. But your initial workup as a student at your level, you're looking for anything that gives you an idea of a small vessel vasculitis or good pastures, now where there's inflammation of both the kidney and the lung. And then if it's an immune complex problem, SLE, because at the initial point, you might not even miss, because you might actually get a lot of history that is suggestive of lupus. If it is post-streptococcal, it's very important that you tend to remember that it's usually 2 to 3 weeks after the infection. So if somebody has had a pharyngitis just a day or two, and then he has got a picture of glomerulonephritis, that is unlikely to be post-streptococcal. The one that is likely to be 1 to 2 days post an infectious process is IgA nephropathy. That's usually a big difference that maybe there's a few questions that you could be asked at your level. IgA usually gives you a problem 1 to 2 days post an infectious process, especially an upper respiratory tract infection. If you have an IgA nephropathy together with extrarenal, that is HSP. If you have 2 to 3 weeks post an upper respiratory tract infection, you have your ASO titer antibodies, and you have a nephritic pattern, that is likely to be PSGN. If you have a young lady with malarash and low platelet and anemia with a nephritic picture, and ANA positive, that is lupus nephritis. So of all the things that you will see here, the one that you tend to read more and familiarize more is PSGN. I'm saying more of PSGN because that is the commonest infectious agent, but it can be it can be post-infectious of any bacteria, not necessarily streptococcal. So please remember, the immune complex group is the one that you should be familiar with at your level, both the lupus and the PSGN. The anti-GBM, not a common one, and the ANCA-associated small vessel vasculitis is not very common. It's actually one in a lifetime diagnosis for most of us. So that is how you approach nephritic diseases. So that is why you see when people are evaluating, because we don't have a biopsy, we don't have anything, we don't know, because a biopsy is usually done later on when we have no clue. So you see right off the bat, people think that, okay, I don't know what's happening. I will ask for an ANCA, both C ANCA and P ANCA. You ask for an anti-nuclear antibody. You ask for a C3 level just to look for the ones with the low complement. In a setup where all these things are provided, you can actually put all these diagnostic evaluation at the beginning, and then now make sense once the results are out. In your history, you have to allude that you have been looking for symptoms and signs that are suggestive of lupus. You have the way they have clearly mentioned the history. That's why they have been talking about the throat infection. Then the Goodpasture syndrome, you have to mention if there is a history of hemoptysis, because that is how it presents most of the times. And then the palpable purpura in your evaluation, it will give you an idea of small vessel vasculitis. One more thing that I need to clarify, there's something called RPGN. So RPGN, you realize in my diagnostic evaluation I did not mention. So RPGN is not a cause as an entity. Any of these things can easily give you a rapidly progressive glomerulonephritis. And histologically, it's just something that you need to remember has got a crescentic presentation in histology. So most of these things that give you nephritic, from the ANCA associated to the anti-GBM to the immune complex, can give you end-stage renal dialysis within weeks, within days. So that, if you have a histology with crescent, is called an RPGN. And then now the cause is usually found out later. So you do an immunofluorescence staining. If there is no staining, that's called post-immune. Basically means this is an ANCA related. If you have a linear one, that's an anti-GBM. If you have a granular crescent, that is likely to be the immune complex one, SLE and the PSGN. So that is what I will tell you as a diagnostic evaluation. I hope it best a little bit makes sense, so that at least when you're approaching nephritic syndrome, you remember, okay, once I get the initial hallmark features, I know what to evaluate in those three buckets: ANCA-associated, anti-GBM, and the immune complex. If it is nephrotic syndrome, it's either primary or it's either secondary. Primary is minimal change disease, FSGS, membranous. The secondary is diabetes, preeclampsia, amyloidosis, and lupus nephritis. The only two that gives you both a nephrotic and a nephritic is lupus nephritis and the membranoproliferative glomerulonephritis. If you have that as your take-home message, I think nephrotic will eventually make sense. Now, please ask all the questions that you have, so that at least by the end of this discussion, people will have gotten one or two things. If you have a question, write it down or even ask. Any question? Or shall I ask a question?
Okay, I have two questions.
Yes, please. This is Dr. Abdullahi.
Yes.
Okay, carry on, Dr.
The first one is in terms of the management of hypertension in nephritic syndrome.
Yes.
There was a place in the slide where Najma said, like, you wait to give S or ARBs until I don't know when. So that one, please clarify. And what medications should we use in when the patient is hypertensive?
Okay.
The second one is there was the issue of giving Clexane in complications, preventing complications of nephrotic syndrome. So what exactly is it preventing?
Fantastic. Two very important questions. So question number one, I think Najma has been very clear. She mentioned that if you're trying to prevent, you're trying to take care of hypertension. For example, this is a patient with nephritic picture, for example, because that's where you tend to see AKI. You don't see AKI in nephrotic. And then you have hypertension of 160s, 120s diastolic. Your choice of antihypertensive should not be an ACE and ARB in that setting, because an ACE and an ARB, what they will do, because they actually tend to cause vasodilatation of the efferent arteriole, they decrease your intraglomerular filtration pressure. So what happens, whatever that you've been filtering is reduced, your filtered load is decreased. Remember, creatinine is also filtered. So if once you have a decreased intraglomerular pressure, you have a decrease in the filtration of creatinine. So by the time you do your subsequent UECs, you see a bump of urea and creatinine. So they tend to worsen the AKI. So in that setup, at the beginning, you do not use an ACE and ARB. Choose your CCB, choose your hydralazine, choose your metal dropper. Once you're out of the picture of the AKI, now you can take advantage of the anti-proteinuric effect by introducing once you're out of AKI. So in that time when the ureas are high, the creatinine are high, choose another antihypertensive. Don't use an S and an ARB. I hope that is clear. The second question regarding nephrotic syndrome, I think this is something that a mechanism that you should all be familiar, that nephrotic syndrome is a hypercoagulable state. You're losing antithrombin 3 predominantly, and you get predisposed to thrombosis, both arterial and venous being the common one. So because you have a predisposition to thrombosis, there is a tendency of anticoagulating such patients. So who do you anticoagulate? Do you anticoagulate everybody, given that these patients are hypercoagulable? No. I don't think you will be asked at your level, but this is what you need to know. Anybody who has got nephrotic syndrome, according to the KDIGO guideline, says you look at their serum albumin. If the serum albumin is low, meaning they have less than 20 grams per liter, that is an idea that, okay, this person, the tendency of this patient losing more protein, because antithrombin 3 is also basically here is less than 20 grams plus any of the following. You have heart failure with New York Heart Association class 3, class 4, or more than 30, or you have, for example, a resist. You've had any, and actually is necessary. You can actually, let's say 18 gram, 3 gram, 20 gram. Hello, am I breaking?
Yes, Doc. Yes, Doc. Kindly, you are breaking. Yeah. Sorry,
there was a phone. I mean, somebody trying to reach me out. So let me just repeat. So anybody with low albumin, with any other risk factor for thrombotic event should be anticoagulated, and you can use a direct oral anticoagulant. So if you have low albumin, recent history of surgery, you will be anticoagulated, and you have nephrotic syndrome. Or the one that is people actually tend to forget, if you have significant proteinuria of more than 10 grams. So we say the cutoff is 3.5, isn't it? So if you have 11, 12, and your albumin is low, the assumption there is the chances of you losing your antithrombin 3 is equivalently high. You have to be anticoagulated, and you will be given DOACs unless there is an obvious contraindication. I hope I've answered your question, Dr. Any other question?
Yes, thank you.
Okay, if you guys don't have a question, I'll ask a question. Anyone to answer? Why do we have a low complement in some of these nephrotic diseases? Why do we have a low C3 or low C4? Anybody?
So, Doc,
yes,
probably the C3, C4, they are the complement. So they are used in the immune deposition. So we have the antibody, antigen, and the complement now being deposited, being part of the immune deposit.
No, not deposition. You're almost there, but they're being consumed. They're being consumed because the antigen antibody complex is activating the complement cascade, and one of the proteins in the complement cascade is your C3 and C4. So there's so much consumption of C3 and C4 because of the antigen antibody complex activating the classical pathway of the complement system, and you tend to have low C3, low C4. Is Dr. Khalif here still? Okay, Dr. Khalif is not with us. Is there any other question? Okay. There's a question that was asked by somebody. At what point did you decide the patient was good for discharge? What parameters were used? Dr. Abdullahi.
So, Daktari,
yeah,
the reason is one, because we had achieved the normal range of blood pressure. That was 132, I remember, historically. So it was within normal range. Also, the potassium from 7, we are almost approaching. It was 5.9, almost 5.6 there. So we were almost there. And the patient was stable, able to pass urine, and he was a good appetite and in good condition. So the patient, even we were with the family, they were doing well. And even, yeah, so most of the parameters was normal BP, urine was passing well, the potassium, the creatinine were coming down very well. So he was just now to be followed with a renal clinic as an outpatient. Then now, suddenly is when now he desaturated with cough, low saturation, and then we had now to put him on oxygen now. And now think what else now was wrong? Was it because of the anemia, or was it because of the effusion? But generally, the patient was in good condition. It was just a sudden deterioration that came. But before that, he was in a range to be discharged and followed up in the outpatient clinic, in the renal clinic for 2 months as an outpatient.
Okay, there's a question, 2 questions actually. Somebody's asking for a recap of the crescentic hallmark of RPGN. So just to put it into perspective, all these causes of nephritic syndrome that I've mentioned, whether it's the anti-GBM, whether the immune complex one, or it is the ANCA associated, they can give you a progressive disease that you get end-stage renal disease in weeks, or even days, or even months. That rapid progression is what is called the rapidly progressive glomerulonephritis. And for you to call it that term, they have a histological hallmark that where you see you have a crescent within the glomerulus on histology. So there's a lot of inflammation going on. So you get fibroblast deposition. So you get a fibrotic picture and a crescent on histology. So anytime you get a crescent on histology, that is an RPGN picture. So it's a rapidly progressive glomerulonephritis. And the causes now can easily be any of these. So for example, you say, I have somebody who had progressed from a normal kidney function to end-stage renal dialysis required in less than, for example, 2 months. So that is, in clinically, it's actually a picture that makes sense that you can say this is an RPGN. So you confirm by doing a biopsy, you get a crescent on light microscopy. So now, for example, then you later on have to say which of these nephritic causes can give me this picture. So what you do an IF, immunofluorescence staining. The ANCA-associated ones, they don't tend to have anything. So they have a negative immunofluorescence. They're called post-immune. So if you have no staining on your immunofluorescence, that is a post-immune. Then you think about the ANCA-associated vasculitis. They're called the ones that I've mentioned, anti-EGPA, sorry, and MPA and GPA. If it gives you a granular picture of immunofluorescence, then that makes sense. This is likely to be PSGN or SLE or the rest of the immunocomplex deposition. If it has a linear deposition on immunofluorescence, that is anti-GBM. So that is actually how you take advantage of immunofluorescence staining, just by making a diagnosis after you have done your clinical evaluation and say this is an RPGN, did a biopsy, the biopsy showed a crescent on light microscopy. Now you can do a immunostaining, and then from there, if it is granular, you think this is an immune complex mediated. If it is linear, anti-GBM. If it is post-immune, means there is no staining for C3, no staining for IgG, no staining for anything. That's like post means lack of. So there's no immune. That is now the ANCA-associated vasculitis. I hope that is clear. If it's not clear, please just ask the question again, or what's not clear. And then, can TTP be a differential? Well, thrombotic thrombocytopenic purpura could be a differential, but I think there's so many things that are missing here. So TTP usually present with a pentad of, number one, we have an AKI with low HB, low platelets, and then you have fever, and then you have neurologic dysfunction. If it's just the AKI together with anemia and thrombocytopenia, that is hemolytic uremic syndrome. Once we have the fever and the immune dysfunction, the neurologic dysfunction, that is the pentad, that is TTP. From our picture, it's not because we didn't have a low HB, we didn't have a low platelet, we just had an AKI, and there's no history of fever that were reported, no neurological dysfunction. And then most importantly, when you do your peripheral blood film, you get schistocytes, you get fragmented RBCs, which we don't have here, But if we had, probably yes. But right now, it's not a differential that is at the top of what we are evaluating. Someone is asking, in the management of nephritic syndrome, especially edema, should there be any restriction of fluid intake to an amount of insensible loss? It's usually a patient-dependent assessment. If the patient has got an AKI and has got edema, most of the times, if you restrict fluid, the whole idea is so that you don't overload and tend to run to dialysis. But if you are dialyzing those patients, you usually have some liberal, restriction. Give them 1 to 1.5. They are comfortable. But if you give them significant amount of fluid and you're not dialyzing, or if there's dialysis needed, you can't dialyze, you tend to restrict their fluids. The question that I remember Dr. Khalif asked of steroids, at the very beginning when this patient come, when you have no clue and you think a picture of an acute kidney injury with hematuria and RBC cast that you've seen on microscopy with oliguria or vanuria, yes, pulsing them is usually a very acceptable treatment approach. And then as you evaluate for the causes, yes, pulsing those patients is usually an acceptable mode of approach. But if you had a clear diagnosis, maybe you thought this is SLE, and you knew this is SLE associated kidney injury, and what we call lupus nephritis, an MMF drug, that is mycophenolate mofetil, is usually the drug of choice. Is there any other question? I hope nephritic syndrome is clear, because this is what is likely to be associated to our patient. We didn't have a very clear cut nephritic syndrome, so we just brought something that is clear to it. So you will excuse us, probably some of the history is not in keeping with a clear-cut nephritic syndrome, but most times you don't see such patients. So you see a patient with a mixed pattern of diseases whose initial evaluation is not complete. So we don't have an anchor, we don't have an ANA, we don't have a biopsy. So unless there is no any other question, I think I would stop there. Dr. Abdullahi and Dr. Najma, please take over.
Thank you so much, Daktari, for your time and for your support. We thank you so much. May Allah reward you so much for your advice and input. So back to the Msaun Academic Committee to give us the vote of thanks, inshallah. So the Msaun KNH Academic team.
Assalamu alaikum.
Wa alaikum salam wa rahmatullah.
Thank you everyone for attending the session, and thank you so much Dr. Ahmed for the informative session, and to you presenters as well. Thank you so much. We learned a lot today. See you inshallah in the next grand round. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum salam wa rahmatullahi wa barakatuh. Thank you so much to everyone. Ma salam.